This is Dr. J. Patel speaking today on aortic dissection, one of the important 22 don't miss diagnoses in medical student radiology. Regarding aortic dissection, today I want to go over some goals and objectives, which include a background on the history and prevalence of aortic dissection. I want to strengthen your understanding of dissection and give you a description on its pathogenesis and risk factors. And I also want to review the classic radiographic findings of aortic dissection. Some facts and figures about aortic dissection. It is the most common aortic emergency, and it is a common thing to see in the emergency department setting. So some names of people who you may recognize who have suffered from aortic dissection include John Ritter, who was a cast member of the 80s hit TV show Three's Company, King George II, a prominent English monarch, and Dr. Michael DeBakey, a prominent vascular surgeon, who at the age of 97 suffered from an aortic dissection and was repaired by his own named procedure. This is John Ritter, this is Dr. Michael DeBakey, and this is King George II. Risk factors for the development of aortic dissection include hypertension, which is actually the strongest risk factor, and it's seen in about 75% of patients who suffer from aortic dissection. It has a male predilection and occurs at a 3-to-1 male to female ratio, and typically in the age range of 50 to 70 years old. Many other risk factors for dissection include trauma, including blunt trauma or cardiac catheterization or aortic surgery for whatever reason, such as a valve or root repair. Some vascular inflammatory conditions such as giant cell or Takayasu's arteritis, which are large vessel arteritides, can also predispose to the development of dissection. In young patients, you can think of other things such as heavy weightlifting or cocaine abuse. Pregnant patients could have aortic dissection secondary to preeclampsia or eclampsia, which can cause hypertension. Congenital anomalies such as bicuspid valves and coarctations of the aorta, connective tissue disorders such as Marfan's disease and Ehlers-Danlos, and some genetic conditions such as Turner's syndrome. Aortic dissection. Some of the clinical signs and symptoms that you may hear in the clinical setting of aortic dissection are severe chest pain, which is actually seen in about 90% of patients with dissection. And in all the clinical settings you've seen and in all the important tests you've taken in medical school, like step 1, 2, and 3, you get that classic history of acute tearing onset of pain spreading to the scapula or even progressing downward. And if you hear that history, you're automatically alarmed to the diagnosis of aortic dissection. It can be sudden, it can be abrupt, it could be substernal or intrascapular. If it's substernal, those are typically seen in type A dissections. If it's intrascapular, typically in type B dissections. And it can radiate, like I said, to the back, to the neck, or even to the abdomen if the dissection rips down towards the abdominal vessels. So basically what's happened pathologically in an aortic dissection is you have lumen of the aorta right here, and there is blood inside the lumen, and then you have 3 layers to the wall of any large vessel, and they include the intima, the media, and the adventitia. The intima is this thin purple looking line, the media is this jagged red line, and the adventitia is this yellow line. And in dissection, these hypertensive patients, they keep getting a pulsation on an area of weakness in the intima, and eventually the intima is breached and blood dissects into the media of the vessel wall. And it can dissect forward or backward, or it can even rupture through the adventitia, and in that case you would have rupture of the aorta and the patient may progress to death. Here is another cartoon schema describing what's happening in dissection, and it's showing you here the intima, the media, and the adventitia, which is fed by these blood vessels called the vasa vasorum. Okay, and so we will continue on. Describing the pathogenesis, as I had said, there's an intimal breach, and blood accesses and propagates into the media of the vessel wall, lifting the intima up, and this creates 2 channels, a true lumen and a false lumen. The true lumen is the lumen that connects to the left ventricular outflow tract, and the false lumen is the new lumen that's created inside of the vessel wall where the dissection is propagating through. So the dissection can stop in the wall, in the media of the blood vessel, it can break back through the intima, or it could break out through the adventitia, which is aortic rupture. Potentially these dissections can also thrombose themselves off. The blood won't be liquid, it'll just clot itself off and it won't propagate. Here is a chest radiograph, a frontal chest radiograph in a patient who we have no history on. So if the day before this guy had a normal x-ray and this aortic knob here was not prominent, and he comes in today with this x-ray, you can assume that something acute happened to his aorta. And if the history was acute tearing onset chest pain radiating to the back, you'd be very concerned about a dissection, and this is what it could potentially look like on an x-ray, and you would further evaluate that with a CT scan with contrast. However, if I gave you no history and I didn't tell you anything about this patient and he just presented one day with this radiograph and had no priors, you wouldn't be able to tell if this was an acute abnormality, because we do see a prominent aortic knob here and we see calcifications in the aortic wall. So this could just be an aortic aneurysm or dilation of the aorta for whatever reason, and that could either be the dissection or just because of an aneurysm. So we'd have to evaluate that further no matter what, especially if a patient can't give us any history or is unreliable or is diabetic and may not be experiencing any symptoms. So in this case, we would progress to CT to figure out what's going on. Now here we have an axial and coronal CT with contrast through the level of the aorta, and we are demonstrating a nice ascending aorta here with contrast within the lumen that looks homogeneous. It looks like a nice round light bulb, which is what we'd like to see. And here in the descending aorta, which is next to the vertebrae on the left side, we have a lumen here which is well opacified with contrast and bright just like the ascending aorta, and then another lumen here which is the false lumen, which is not as bright as the true lumen. It's bigger than the true lumen, and then you have this area of darkness in between the two, and that is the intima that's been breached. It's an intimal flap. So this is the classic appearance of an aortic dissection on CT scan. Here is another scan of a Grady patient who has, we're going through the level of the abdomen, and he's having abdominal pain, not acute tearing onset of chest pain, but we got a CT with contrast to evaluate what's going on, and we know we're in the abdomen because we're seeing the kidneys enhancing here, we're seeing the liver here, and we're seeing this large aorta here in the abdomen with a line right through it, the intimal flap, and two different lumens. So this is the classic appearance of aortic dissection on CT scan. There's a classification system for aortic dissection, and there are two different types. There's the Stanford-Daly system and there's the DeBakey system. I choose to remember the Stanford-Daly system because it's an A and a B system. I only have to remember two things. So a type A dissection is the ascending aorta is involved. A type B dissection, the ascending aorta is not involved. And the way I remember this is A is for ascending. So type A, ascending aorta is involved. The DeBakey system is a little bit harder to remember because it has three parts. It's type 1, 2, and 3. So I don't know about you, but I'd rather choose to just remember type A and B. It's just two things. So DeBakey was a vascular surgeon, and if you want to remember his system, he organizes things based on what's most important to him. So type 1 would be something he's got to operate on, an ascending and descending aorta dissection. So that's a pretty important thing to him, and that's why he probably called it type 1. A type 2 dissection involves ascending aorta only, and a type 3 DeBakey dissection involves the descending aorta only. If you want to correlate the Stanford and DeBakey systems, you can try to remember it with type 3 rhymes with type B. So 3 rhymes with B. A type 3 DeBakey equals a Stanford type B. The terminology that we just used to describe ascending versus descending dissections comes from these anatomic descriptions. The ascending aorta is considered basically beyond the sinus of Valsalva, and the descending aorta is considered distal to the origin of the left subclavian artery. Aortic dissections can propagate in the antegrade or the retrograde direction. So theoretically, a type B dissection, if it propagates retrograde, can become a type A dissection. Here is some images of a Stanford type A dissection. Here we have a contrast-enhanced axial CT through the level of the aorta, and here is the ascending aorta, and here is the descending aorta. We know this is ascending because it's anterior to the carinal region. This is the right bronchus and the left bronchus, and here is the vertebrae, and here is the descending aorta next to the left side of the vertebrae. So ascending aorta, and here we have an intimal flap through it, descending aorta, and we have an intimal flap through it. So Stanford type A, the ascending aorta is involved in some way. This is a Stanford type A dissection. Here's another picture of the same diagnosis basically. Here we have the arch of the aorta. It's flayed out here. This is the arch. And here we have a dissection flap, an intimal flap through the level of the arch of the aorta, typical of a Stanford type A dissection. Here is a Stanford type B dissection, and here we have a sagittal oblique projection of the aorta, It's flayed out in what's known as the candy cane appearance, and here we have the great vessels coming off. There's one, there's two, there's the third great vessel, the left subclavian artery. Distal to the left subclavian artery, we have an intimal flap, this dark line separating a true and a false lumen. This is a typical appearance of an aortic dissection. And here is a fancy 3D reconstruction of the aorta in the candy cane view, demonstrating the three vessels, 2, 3. This is the left subclavian. Distal to the left subclavian, we have a dissection flap, and a true lumen, and a false lumen. Stanford type B dissection. Here are gross anatomic images in the coronal and the sagittal plane, showing what's basically going on anatomically. Here's the aortic root basically, beyond the sinus of Valsalva, up until this part right here, which is the left subclavian artery. Everything in the aorta from here to here is considered ascending aorta. Descending aorta is considered distal to the takeoff of the left subclavian artery. So if this is the left subclavian artery, we go distal to it. Anything dissecting in the wall of this aorta would be considered a type B dissection. Here are some cartoon images basically describing what happens in ascending and aortic dissections and type B dissections. Here's an ascending one where we have an intimal breach, blood dissecting in the media of the wall in the ascending aorta. Type B dissection, we have an intimal breach, blood dissecting in a retrograde or antegrade fashion in the descending aorta. If this blood dissected all the way up to back here, it would make a type B initially transform into a type A. So the management of aortic dissection, and the reason why we even classify these in the first place, is we have to make a delineation as to what goes to surgery and what is treated with medicine. Type A dissections are treated with surgery, and type B dissections are typically treated medically. The medications that we use to treat aortic dissections are basically to control high blood pressure. So beta blockers, sodium nitroprusside, esmolol, labetalol drips, all these things, and in consultation with your medical colleagues in the ICU, are used to treat aortic dissections in the acute setting. Surgery is involved for type A dissection, so if you see a type A dissection, you need to call your vascular surgery team or your general surgery team, or potentially even your interventional radiology team for management. And surgical management has been shown to be, in the medical literature, superior for an acute ascending aortic dissection. That's seen in both the medical and surgical literature. Some of the complications that could occur with aortic dissection include hemopericardium. Basically, if you have an ascending aortic dissection that goes retrograde, it can dissect into your pericardial sac, and you can imagine that if blood fills your pericardial sac, it'll prevent your heart from beating normally and cause cardiac tamponade. Dissections can involve the branch vessels, so the great vessels such as the innominate artery, the left common carotid, and the left subclavian can be involved with dissection if the intimal flap chooses to go in that direction. Dissections themselves can thrombose off. They can cause ischemia, and they can do this by, if an ascending aortic dissection goes retrograde down to the orifice of the right coronary artery, you may occlude the orifice of the right coronary artery, and the patient may experience symptoms of a myocardial infarction, and their labs may also reflect the same thing. But you have to think about aortic dissection in that case. Aortic dissections can also lead to aneurysm of the aorta because it's damaging the wall. It can lead to rupture of the aorta, and it can cause aortic regurgitation in the acute setting. If an ascending aortic dissection goes retrograde to involve the base of the aortic valve leaflet, it can cause a flail aortic leaflet, and you can get acute aortic regurgitation and flash pulmonary edema. Here's an axial CT scan through the level of the heart, and here we have the heart, and in the pericardium, which should normally be a thin line, we have this dense, thick material, which if we put Hounsfield units on it would measure 40 to 70, and that's consistent with acute blood in the pericardial sac. And this patient clinically would have signs and symptoms of pericardial tamponade. Here we have an axial CT with contrast showing branch vessel involvement. Here we have an intimal flap in the innominate artery and an intimal flap in the left subclavian artery. Notice 1, 2, 3, the main branches off the arch of the aorta. You can have organ or bowel ischemia in the setting of aortic dissection, and here we have the abdominal aorta with an intimal flap through it, this dark line, and the right kidney we see here is not well opacified with contrast, as the left kidney is. Ignore these findings, these are just simple cysts, but the rest of the left renal parenchyma is enhancing well. The right renal parenchyma is not. It's because the aortic dissection has involved the right renal artery. There's also bowel wall thickening here, which is a sign of ischemia. Here is an axial CT with contrast that we saw before, and we have an intimal flap indicating an aortic dissection in the abdominal aorta, which is dilated to definitely greater than 3 centimeters. I don't have a picture to show you what happens when aortic rupture occurs in the setting of aortic dissection because this one image basically explains it all. Aortic dissection in radiology is typically diagnosed by CT scan, as these are widely available, they're very easy to perform, they're very accurate, and you get very quick results. It has a high negative predictive value, and also when you get a CT scan with contrast, maybe you may not find a dissection in a patient with chest pain, but you could find something else, like a pulmonary embolism, or maybe the patient has a pneumonia or another reason for having chest pain. In unstable patients with low GFRs and poor cardiac function, you can do a transesophageal echocardiogram to diagnose that, or you could also even do an MRI for the dissection diagnosis. And MRI is actually considered the gold standard, but we don't do it as much since this is an expensive test and it takes a lot longer to perform. But typically if we do this, it's because a patient may have a contrast allergy or an anaphylactic reaction to the iodine contrast dye used in CT scans. Some pitfalls in the diagnosis of aortic dissection on x-rays. If you have a normal x-ray, and let's just say that this patient has a normal x-ray, you may miss the diagnosis of aortic dissection because 20% of patients with a normal x-ray can have aortic dissection. And this patient had an x-ray, and then he eventually went on to CT because it was unclear as to what was going on, and we saw an intimal flap here in the ascending aorta and an intimal flap here in the descending aorta, this dark line coursing through the blood vessel, which you should not have, and that's consistent with Stanford type A dissection. So this concludes my podcast on aortic dissection, one of the 22 don't miss diagnoses in radiology. I hope you enjoyed it.